Trauma is considered a surgical disease that results from the outside force of energy impacting the body, causing changes. Alcohol, motor vehicle crashes kill someone every 30 minutes, injure someone every 2 minutes, and cost $51 billion. Domestic violence is now called intimate partner violence, is the leading cause of injury to females. Blunt force trauma occurs with contact sports such as football, motor vehicle crashes, blunt force injury, falls. The blunt force injury could be like a baseball bat. To estimate the force of the trauma, you want to multiply the weight by the speed. So if you have somebody who weighs 100 pounds, times 6 going at 60 miles an hour, and they have a vehicle crash, that's 6,000 pounds of force on their body. 3 tons. That's amazing. Changes in velocity cause lacerations or crush injuries of the internal structures. Penetrating trauma is caused by bullets. The hole that goes in is about that comes out is about 5 to 30 times greater than the size of the bullet. There are knives and impalements. There are different phases to trauma care. And deaths occur in a trimodal fashion. There's a figure on page 940 that shows it. 50% die before help arrives. 30% die within the golden hour. That's from the arrival of the EMS to the hospital until they get to surgery. And 20% die weeks after the injury due to complications. EMS does the pre-hospital resuscitation to the hospital, and ER does the advanced trauma life support. The hospital course is governed by the ABCs. A is airway, and you want to stabilize your cervical spine. You want to look, listen, and feel. If the patient can talk, they have a patent airway. If they have non-purposeful movement and or number 8 on or below the Glasgow Coma scale, they need airway help. B is, of course, for breathing. You need to check their chest wall movement, rate, depth, symmetry, and auscultation. Their treatment would be a chest tube, endotracheal tube placement, oxygen, and a pulse ox. C is for circulation, decreased cardiac output, decreased perfusion, decreased fluid volume, level of consciousness, their color, their pulse. Treatment is to put them on monitor, follow ACLS protocols, IVs for fluid replacement with at least a 14 to a 16 gauge catheters put in. D is your disability. This is your neurocheck, your Glasgow Coma scale. And with your neurocheck, you're going to use the acronym AVPU. A means alert, V means responds to verbal stimuli, and P is responds to painful stimuli. U means that they're unresponsive. You check the pupils and you use your Glasgow Coma scale. E is for exposure. Exposure and environmental control. This is when you remove all their clothes and protect them from hypothermia. There is a table on 941 that discusses these items, and a box on page 942 for the lab values that are supposed to be drawn. The resuscitation phase is when they go from ER to ICU. Now, I'm serious about removing all their clothes and looking. And I'm serious about it because as a nurse, I took care of patients in coronary who started out in ER, had Foley's put in, and when they came up to the acute care unit, when we finally took their clothes off and looked, we found some strange things in their underdrawers. One time, it was a 32 special. We had to call security to remove that gun. The next time, it was a dead rat. I didn't appreciate either episode. So please, before you put a catheter in somebody, check to make sure their pants are empty. For all those nurses who then have to take care of them afterwards. The resuscitation phase is when what occurs most often is hypovolemic shock. To prevent this, you start 2 large bore IVs and you give them lactated ringers, sometimes 1,000 milliliters an hour. And you may want to warm those fluids, particularly if they are hypothermic. You want to type in cross-match, and if they have a lot of blood loss, you're going to use an auto transfusion. Put in a Foley catheter. Again, look around the area when you put that in, and an NG tube. Your goal is to provide adequate tissue perfusion of the oxygen and nutrients. Your secondary survey occurs when they're up in the acute care unit. These are after the vital signs have returned to normal, so it's oftentimes in the ICU or coronary. This is when you do a thorough inspection of the body. You get a history of the injury, and there is a box on 942 that tells you the questions to ask. You want to obtain their past medical history, and you use APPLE as an acronym. Do they have any allergies? Medications they're currently taking, past medical history of pregnancy, their last meal, the events and the environment to rule out any injury. EKG, X-rays, diagnostic lavage, ultrasound are done during this time frame. And don't forget the family. Now is the time when you can talk to the family. They oftentimes know what happened to start with, but they're very much involved with what's going on with this person. Don't forget the family. The critical care phase, when you send somebody there, you need to give an appropriate report using SBAR, where it's the situation, your assessment, and your report and what you want to do about it. This is on page 943 for the format to follow. The effects of the trauma resuscitation on the future of care are found in a table on page 943. Be aware of complications. Adult respiratory distress syndrome, multiple organ dysfunction syndrome, sepsis, shock, all could occur. You need to balance the oxygen supply and demand. Assessment is an ongoing process with formal reevaluation of all body systems every 8 hours, a focused assessment every 2 to 4 hours, if not more frequently. It's really important. Traumatic brain injury causes 50% of the deaths from trauma. There are 3 types of primary injury. Mild, you'll have loss of consciousness for 15 minutes, but your GCS will be between 13 and 15. Moderate, you'll have loss of consciousness for 6 hours, and your GCS is now between 9 and 12. These patients still do not need to be vented. But severe is when the GCS is 8 or below. These patients probably need to be vented. Secondary injury occurs because of ischemia, increased cardiac output. The edema occurs because of an increase in permeability of the blood-brain barrier. It will cause an increase in intracranial pressure. Hypertension can occur. Metabolic changes can occur. That increased CO2 causes vasodilatation with a resultant increase in intracranial pressure. Hypotension causes a decrease in your cerebral perfusion pressure, and a hypoxia can occur. These are diagnosed with a CT scan, if the traumatic brain injury, that is. And if the patient is hypotensive, you need to check the pelvis, the chest, and the abdomen for another possible injury site. Treatment is surgery to remove the lesion or the fluids, and anti-epileptic drugs because they will need them. 90% are non-surgical cases managed by assessing your intracranial pressure, your cerebral perfusion pressure, pain, and oxygen. There's a box on page 949 for nursing diagnosis and suctioning recommendations. A skull fracture may cause a fistula or leakage of the cerebrospinal fluid. It's diagnosed by a CT scan. Symptoms of a basilar skull fracture may show battle sign. This is a bruise over the mastoid bone. Or raccoon eyes. This is a bruise around the ears. And they'll have otorrhea and rhinorrhea. In other words, cerebrospinal fluid draining from the nose and the ears. A concussion is a loss of consciousness lasting seconds to hours. If it lasts 5 minutes or more, they need to go to the hospital. Signs and symptoms are confusion, disorientation, amnesia, headache, dizziness, nausea, inability to concentrate, and fatigue. An example is my brother-in-law, Frank, was on his way home from work and fell asleep because he wasn't used to working nights. And he fell asleep and was hit by a truck and a pickup. Ended up hanging upside down in his own pickup. Had to be life-flighted to St. Vincent's. Had a loss of consciousness. And it was really interesting because since it was traumatic, and he had had a handlebar mustache, they only removed half of it, not the other half. And he had a beard, and they only removed part of that. And then they also had, he ended up with a pelvic fracture and a contused kidney, and he remembers nothing of the accident because he had a concussion. A contusion is a bruise of the brain. The coup injury is at the site of the impact, and that bruising can cause a hemorrhage in the frontal temporal areas depending on where it was impacted. And then a contra-coup injury is when the brain, which is not sutured in place or anything, it's floating up there in cerebral spinal fluid and on the spinal column, pounds backwards and hits on the opposite side. There's a picture of this on page 945. This can increase the area of damage over 2 to 3 days with a resultant increase in intracranial pressure. Temporal lobe edema will affect the midbrain. Patients here deteriorate rapidly. It takes 3 to 5 days to evolve. It may require surgery. It's really important that you assess their pupils and their vital signs closely. This is also diagnosed with a CT scan. A hematoma causes increased intracranial pressure. If it's epidural, that means it's above the dural. Epi means above. It's a tear of the middle meningeal artery due to a low-impact injury, such as a fall, or a high-impact injury, such as a motor vehicle crash. Symptoms are a brief loss of consciousness to lucidity, and then loss of consciousness again. They all have an ipsilateral pupillary dilatation. That means on the same side as the injury, the pupils will dilate. That becomes fixed and dilated over time. They'll complain of a headache and feeling sleepy. This is diagnosed with CT scan. There is a picture of this on page 948, and this is treated with surgery to fix it. A subdural hematoma means sub means under, so it's under the dura. A coup, contra-coup injury due to acceleration, deceleration, and rotational forces can cause it. There are 3 types. You have acute, which requires immediate surgery. Subacute, which occurs over 2 to 14 days after the injury. And chronic, that develops over days to months later. Your symptoms are vague and insidious. Your recurrence is frequent. Occurs mainly with the elderly and alcoholics. Intracerebral is due to a skull fracture, penetration or rapid acceleration, deceleration, and rotational forces. This means it's within the brain. There's a picture of this on page 947. And your symptoms are those of increased intracranial pressure. Surgery may be an option. That's why there's a question mark. It may or may not be an option. But this finishes part 1. We'll continue part 2 of trauma whenever you click on it. Thank you.